few years ago already. But once you detect lung collapse and your patient is hemodynamically stable, you can use a recruitment maneuver. I don't want to discuss in detail how or which maneuver he uses, but you can apply a recruitment maneuver and look with lung ultrasound how this lung collapse goes into a normal lung, as you can see here. It's better to see in this video where you can see the lung collapse, consolidations, B-lines, etc. During your lung recruitment, you will see this all disappears. And then when you kind of, this is the opening pressure, and when you want to determine the optimal PEEP, you should lower your PEEP after the recruitment maneuver, and then just at the point that these B-lines, consolidations tend to appear again. This is the closing pressure, and you should apply PEEP above 2-3 centimeters of water above this level where there is a tendency to reappear. Also, lung ultrasound can be used in terms of hemodynamic monitors, not only lung ultrasound, but also, of course, cardiac ultrasound. It has its place, and simplified, you can tell when a patient is hypotensive and you need to reassess or assess the patient. You can use lung ultrasound and look at the anterior side of the lungs. If you have an A profile, this means you have dry lungs, you can add fluids. Or whenever you see B lines, of course, you will notice, this on the right video, this means probably cardiogenic pulmonary edema. You should avoid fluids, of course, and you need to support the heart. So these are two examples, and you don't want to miss, like they say in Stanford University, you don't want to miss the low-hanging fruit. Of course, when you started your initial therapy, you need to come up with some more detailed, comprehensive cardiac exam if your patient stays hypotensive, to come up with a differential diagnosis. And as you can see on this slide, you can see that A-lines, dry lungs, are present not only in hypovolemic patients, but for example, also in patients with right ventricular failure. So you need to come up with this differential diagnosis. Just two final slides. As anesthesiologists, we often introduce central lines, and it is published and recommended to use ultrasound for the introduction, the insertion of this central line. But also you need to assess possible complications, and therefore you should try to use lung ultrasounds even before and certainly after the insertion of the central line, and check for pneumothorax. It's easy and it avoids unnecessary x-rays for the patient. Finally, my final slide is this one. I want to mention this in terms of lung ultrasound. You can use transesophageal echocardiography for the assessment of lungs. Of course, not in this kind of detail as in transthoracic lung ultrasound, but it's also easy to detect collections, pleural fluids, but also you can, as you can see here on the two videos on the right, below you can see a lot of B lines before recruitment, and after the recruitment you see the disappearance, almost completely disappearance of these B lines. One thing I need to mention, that transesophageal lung ultrasound has a disadvantage, that it has, you always look at the posterior side or almost to the posterior side of the lung, and there is a gravitational gradient, so you might, the TLU can be oversensitive in terms of B lines and the diagnosis of cardiogenic interstitial syndrome, so you have to be careful with it. And I would like to thank you for your attention.
Thank you very much, Stefan. Another great comprehensive presentation. Now we have documentation of a placement of a central venous catheter. If we should routinely use to document either for medical legal aspect, or do you think that is enough to document that you are visualizing with ultrasound